Now, if you overeat, certainly you can get sick. Before, I almost couldn't get sick. I would have to eat a second pizza to puke with my normal stomach. Now, if I eat a third piece of pizza, I would probably start feeling really bad. If I eat 1.5 pieces of pizza, I start really getting slow through about the second half of a piece of Costco pizza.
So you can fit 1.5 pizzas in that little teeny
Over 30 minutes.
Pieces, not
this
pizzas.
is the other thing. This is the other great thing. So I'm talking more patient stuff with you guys than the other group. If you go to Outback Steakhouse or the big buffet or whatever, you see somebody sit down, the waitress brings over the Thanksgiving special, okay? You know, the big plate of food. Even skinny people in our society, it has gone in 12 minutes. You put a timer on it. Go to Outback. Even a big steak and the potato, most people are 90% through that plate. If you actually time when they take their first bite, 12 minutes. So I can eat a piece of Costco pizza. I can eat, I don't eat bad, but you know, most people know the fast food sizes. I can eat a breakfast burrito. It takes me more than 20 minutes. And that, I'm 2 years out. My first year I could never have done that. I would have eaten half of it and eaten inside, not the tortilla. And even then it would have taken me 30 minutes. You guys just saw me eat these 2 balance bars. It took me 10 minutes just to eat 2 balance bars. That's fast for me. And that gives it time to hit bottom. It gives it time for me to feel full. It's also, that would have been a snack. You know, that's, 5 years ago, 5 pieces of Costco pizza. I could have had 3 easy. I would have stopped after 3 because my wife would be mad. All right. So there are other reasons why we stop eating other than just fullness. Now I am full at every meal. I have satisfaction with food like I never had before. So it's about increasing satisfaction, not about enforcing deprivation. Yes,
How much weight did you lose?
That's fine. I'll show you my badge, my old badge. But my peak was about 305 at the end of residency. Free food, up all night, you know, all the terrible stuff. No exercise. I was able to get down as low as about 265 with sort of boot camp kind of training, but when I got below about 285, I was hungry all the time. It's like asking somebody with asthma to breathe 5 times a minute. Well, normal people breathe 5 times a minute. Maybe you should just try it. You know, it didn't work for me. I went to sleep hungry. I woke up hungry. I was miserable. I wanted to eat anything. You know what I mean? I said I would eat my shoe, and I was almost not joking. I was just hungry all the time. When I lived somewhere between 275 and 285, exercised regularly and tried not to eat total crap. I mean, I still didn't eat great, but not totally crazy. I could live 275 to 285 reasonably comfortably, but I could not happily or sustainably go below that. And now I'm at about 200. I'll probably live, if I'm lucky, like the average sleeve patient, I'll probably live most of my life between 220 and 240. Life is a little stressful right now. I actually have lost weight. Usually before I was gained weight with stress, and now I lose weight. But I'm a little under, actually, probably at 200. I mean, it's ideal. It's a good body weight, but it's not the average. The average is, we're not in the business of making skinny people. We're in the business of making heavy people who are sick healthier. Now, sometimes it's preemptive. Sometimes they're not that sick when they're going to surgery if they're young. But if they're 25 years old and 300 pounds, they're likely to lose 10 years of life expectancy for a male, okay? Now, they may not be sick yet, but when they're 40, 50, they're going to be having heart disease, diabetes, sleep apnea, big problems. So we're not necessarily always solving today's problems.
What is the, I'm sorry, but one more thing. What is the youngest one, would you say, age that got this kind of surgery? I mean,
in the U.S., at some children's hospitals, they will go as low as about 14 years old, 13 or 14. Those tend to be extreme heavy kids. They tend to be the sickest kids who have sleep apnea, who have bad diabetes. But skeletal maturity, I was just telling the previous group, would you think anything of a kid who's on dialysis at age 12 saying, no, you have to wait till you're 18 to get a kidney transplant? You wouldn't dream of it. You'd say, we're going to educate this kid more than we might take more time to get them ready for a kidney transplant. Might have to make sure their whole family's involved, but you get them ready. You don't use it as an excuse to say, no, go away, come back when you're 18. So we're certainly not there with weight loss surgery where that's the routine, but I think ethically, it's unethical actually to withhold the treatment that you know is going to work just because somebody hasn't reached, 18. But that's slightly I'm slightly controversial in saying that, but so that's gastric bypass. Sleeve gastrectomy is basically taking this football-shaped stomach and turning it into a banana-shaped stomach. Okay. Now this is the actually only totally irreversible operation, because this stomach, that part of my stomach, is in Michigan in a landfill. It is gone, not to come back. But it involves using the stapler. We start down here near the pylorus, and we just basically staple along the stomach and remove the whole greater curvature. Okay, so it's removal of about 75 to 85% of the stomach, and you're left with this narrow tube, like looks like a sleeve. One of the nice things about the sleeve is, even though it's not quite as reliable as a bypass, if you need to have it revised, it is very easy to come back and turn that sleeve into a bypass. You just take one staple load across the sleeve, as opposed to taking out a band, which I'll get to next. The sleeve has not been around as long as some of the other operations, especially as a primary operation, but it is actually, other than insurance, it's probably the favored operation in the U.S. right now. If everything were covered equally, it would probably be the leader. Now, it's not as effective against diabetes, and as you'll notice on my little banner, this is specific diabetes and weight loss surgery. Traditionally, we've talked about bariatric surgery as just being for morbid obesity. There's more and more evidence, especially from people of Chinese and Indian descent, that they can become quite brittle diabetics even when they're just 40 pounds overweight. Well, they would never meet the Caucasian criteria for weight loss surgery, but gastric bypass is incredibly effective, more than 85% effective at putting them into remission for their diabetes. And again, like I talked about, our goal is to make people healthier, not skinnier. And so some of these criteria of cutoffs of BMI of 35 or 40 or whatever are being attacked as, potentially racist. That's true. Most Caucasians don't get diabetes until they're over 40, BMI of over 40. But that's no reason to limit it. Not everybody's the same. We need to individualize, just like we do for any operation. So this is a lap band, and this goes around the upper stomach. We put this in through a 15 millimeter port. It comes kind of open like this. I'm not going to take it all the way apart. The port is not attached to it. And we can slide this in, slide that little tubing around the stomach and back through the buccal, and we close it down around the upper stomach. I can show you a full video of this someday, but it ends up being just around the upper part of the stomach here. It's got about ½ inch of stomach above it. And we don't want it to sit on esophagus, we want it to sit on stomach. And this is a balloon on the inside that we fill or empty with saline. The little port is out under the skin on the abdominal wall, and this is up inside, and all the tubing's inside. And you can adjust this with a Huber needle, just like you access a port. It is a portacath, basically. It's got the little metal back and everything.
They slip?
They slip. They can erode, but slipping's the main thing. The most important thing about the band, as opposed to the sleeve and the gastric bypass, is there's really not measurable hormonal changes in the appetite. You get full feeling with the band, and definitely this holds food in that upper stomach and makes you eat slow so you get satisfied, but it's not as strong a tool. And that's the tricky thing. I think a lot of people think, oh, well, one's the same as the other, the same as the other. About a third of people, in my experience, have been wildly happy with their band. It's done everything they ever dreamed of, and they're marathoning bikini models. They're just happy as clams. About a third of people do okay. They may be a little older sometimes, and they don't exercise quite as much, or they may work a white-collar job where they have food available, and so they don't really have meal. They kind of have food through the day. It's easier to sneak food past this a little bit than it is for a bypass or a sleeve. Nibbling, or grazing is really kryptonite. Liquid calories go through this easier with a bypass or with a sleeve. I can eat ice cream, but if I eat a bowl of ice cream, I feel bad, even with a sleeve. And somebody with a bypass is going to feel sick with the dumping high osmolar load. Remember this for your diabetic patients. Apple juice has a high osmolar load. You give somebody a big slug of apple juice, you're going to give them a bellyache and maybe diarrhea. So be careful with the sugar with diabetics if you have somebody with hypoglycemia. It's a good tool though, and if there were no other operations, I'd be happy to put bands in almost everybody, because it's still a very good tool. It's just disappointing probably to less than half, but I think about a third of people who get them really struggle and I put in 350 bands in Duluth, and before I was even gone, before even 100 of them were 3 years old, I had taken out almost 10. That's a fair amount. Now, maybe I didn't believe enough, and maybe I should have pushed more, but we had a lot of people going kind of up and down with their adjustments. We go up and they get too tight, and then we come down and they gain weight, and it can be a frustration. That's why I'm always more guarded about the band. But like I say, probably about a third of people I put them in have just done wonderfully. But in my experience, I didn't start putting them in until about 2006, too. Where are they going to be in 20 years? We know with the bypass, the average patient, 20 years out, there's at least one good 20-year study that shows the average patient 20 years after a bypass still has half of their excess weight off. And like we talked about, it's not skinny, that's not normal weight, but that's the natural history. Most of those folks would have gained weight or been dead. And having half your excess weight off, health-wise, is really all you need for most things except knees. Knees care about every pound. So I'm going to pass this around.
Is this the band where the patient talks about they go in and they get extended a little bit more?
Get adjusted, exactly. You come into the office, we put a needle in there. Yep,
and
we put a little fluid in there, and we can take fluid out too.
Yeah.
We will try not to do band adjustments on Fridays because then people come back on Saturday to the ER rather than to the clinic. So we try not to do adjustments on Fridays.
So is that the only method you're going to use?
Oh no.
Okay.
No, that's the method I will probably use the least. I will use that on somebody who is 75 years old, because I don't want to do too much stapling probably. We will use that on folks who absolutely want that and nothing else because, like I said, it is still a good tool. I would never withhold a good tool because somebody refuses to, you know what I mean? It's not my body, it's their body. It's my job as a surgeon, it's our job as a team to educate patients and to help them make their best decision. If somebody says, look, I just don't want anything but a band, as long as it's not, there are a couple of medical conditions where you shouldn't put a band in, but as long as they don't have that, I'm happy to put a band in.
Is this the most reversible one?
It ain't held in with Velcro. Taking it out is just as dangerous as putting it in terms of, it's an operation. It has less risk of death than a lap chole. But a gastric bypass, the risk of death from gastric bypass is about what lap chole is. It's perceived to be way less risky when it's actually just a little less risky. I say it's the difference between maybe driving a Suburban from here to California as opposed to a nice Dodge Neon, wearing your seatbelts with your airbags on in daylight at the speed limit, not drinking. You're probably going to get there safe in both, right? And if you're in a Suburban at 100 miles an hour at night on ice drinking, I'd rather be in the Neon, thank you very much. So, so the difference is statistically provable, but not necessarily major.